All right, Dr. Elliott.
Great, thank you. Welcome, everybody. It's my pleasure to introduce Dr. Christyn Edmundson this morning. She's still relatively new, I think still less than a year. She's a neuromuscular subspecialist and has been with Swedish, and just a great new addition. A few comments on her background. She is a graduate of Brown University and was also a graduate of Albert Einstein College of Medicine, where she completed her MD degree. She then went on to do her internship and neurology residency at the Hospital of the University of Pennsylvania. And there she was recognized for multiple teaching and clinical awards. And she's continued that here. She's doing a lot of teaching here at Swedish, which we're really grateful for. She then went on to complete her neuromuscular medicine fellowship at Harvard Partners, Brigham and Women's Hospital in Massachusetts General Hospital. And before returning to the Hospital of the University of Pennsylvania, where she continued as an assistant professor from 2017 to 2021. And she's, since that time, joined us here at Swedish, and we're really fortunate to have her. Dr. Edmundson has particular interest and expertise in autoimmune neuromuscular disorders, such as myasthenia gravis, CIDP, inflammatory myopathies, and vasculitis. She's dedicated to medical education, and in her time at the University of Pennsylvania, she served as the director of the Neuromuscular Fellowship Program and was involved in resident education. Her teaching efforts were recognized by an induction as a faculty member of AOA in 2020. And as I mentioned, she's since joined Swedish, where she's the director of the neurology clerkship here at Swedish, and also medical director for a neuromuscular program here in neurology. She frequently speaks at regional and national conferences, including the AAN, and upcoming here at the AANEM will be giving a talk as well. So it's my great pleasure to welcome Christyn. She's been a tremendous new colleague. I'm so glad to have her here, and please join me in welcoming her this morning.
Thank you so much for that introduction, Dr. Elliott. I'm going to share my slides here. All right, so I'm going to be speaking today about immunotherapy and myasthenia gravis. A few disclosures before we get started. I received consulting fees from Alexion, Argenx, Immunovant, and Morgan Stanley, and serve as a paid speaker for Argenx. So the objectives of my talk today are going to be to review the pathophysiology and subtypes of myasthenia gravis, which many of you may be familiar with, but there's some interesting new developments and work that are going on in this area. We'll then review the therapeutic options currently available to treat myasthenia gravis, and with a focus on discussing mechanisms of action of some of the new targeted and emerging therapies that we use for myasthenia. I think this is a super interesting topic. There's a lot of exciting developments happening in this area that are applicable not just to myasthenia, but other autoimmune disorders in neurology as well. So what is myasthenia gravis? I won't spend too much time on this since most of us are probably fairly familiar with it. But essentially, myasthenia is an autoimmune disorder that causes postsynaptic neuromuscular junction dysfunction, which results in fluctuating weakness of specifically skeletal muscles. It's diagnosed through a variety of clinical findings, antibody tests, and electrodiagnostic tests. I could do a whole talk on just how to diagnose myasthenia. It isn't the topic of today's lecture, though. If you have any questions about this, I'd be happy to address them offline at any point. And then myasthenia is treated with a wide variety of therapies, most of which are immunomodulatory. When we look at myasthenia, it's not just one disease. There are actually quite a few subtypes of myasthenia, and we define these subtypes on a couple of levels. So we distinguish between ocular and generalized myasthenia. We distinguish between patients with different serostatus, different antibodies, which I'll talk a little bit more about. And then we also distinguish between myasthenics who have a thymoma or a tumor on the thymus versus non-thymomatous myasthenia. So myasthenia symptoms include ocular myasthenia symptoms of ptosis or drooping eyelids and diplopia or double vision. And patients who have only ocular findings or symptoms are defined as ocular myasthenics. Patients who have symptoms anywhere outside the eyes are defined as generalized. Some of those symptoms can include proximal limb weakness, jaw fatigue with chewing, dysphagia or difficulty swallowing, difficulty speaking, and even difficulty breathing. Folks can present with ocular symptoms and then go on to develop generalized symptoms, but a good rule of thumb is that if someone with myasthenia has had only ocular symptoms for about 2 to 3 years, it's extremely unlikely that they're going to go on and generalize. So usually if people present with mainly ocular symptoms, if they're going to develop generalized symptoms, that happens within the first few years of disease. Myasthenia gravis, as I had mentioned before, is caused by postsynaptic neuromuscular junction dysfunction. So we can see here a nice little cartoon of the neuromuscular junction. Here at the top is the nerve terminal, and at the bottom, this is the actual muscle membrane with a depiction of a bunch of the proteins that sort of participate in neuromuscular junction transmission. And what happens here normally is when an action potential reaches the nerve terminal, the depolarization induces opening of voltage-gated calcium channels. That influx of calcium then precipitates release of acetylcholine into the neuromuscular junction. Acetylcholine then binds to acetylcholine receptors, which are ionotropic receptors. When they open, there's flux of ions across the muscle membrane, which results in depolarization that produces contraction of the muscle itself. So myasthenia gravis is caused by an autoimmune attack either against the acetylcholine receptor or against some of these other proteins that are associated with the acetylcholine receptor on the postsynaptic membrane of the neuromuscular junction. So as I mentioned before, we define myasthenia somewhat by what the serostatus of a patient is. And by far the most common type of myasthenia is acetylcholine receptor antibody positive myasthenia. About 85% of myasthenia patients who have generalized symptoms will have acetylcholine receptor antibodies or AChR antibodies. In contrast, only about half of ocular patients will have a positive acetylcholine receptor antibody. These antibodies bind to the acetylcholine receptor, and they cause their pathologic effect in a couple of different ways. First, they actually cause a functional blockade of the acetylcholine receptor, sort of preventing binding of acetylcholine to the receptor. Next, they can cause cross-linking and internalization of the antibody. So the receptor. So the antibodies bind to the receptor, and then those antibodies themselves cross-link. The receptors get internalized and then are no longer available to participate in neuromuscular junction transmission. And then finally, and very importantly, bound antibodies activate complement, which leads to inflammation, damage to the neuromuscular junction, and overall loss of integrity of the neuromuscular junction. So there are some great old pathology pictures out there where the neuromuscular junction of folks with chronic myasthenia becomes sort of very flattened and denuded. There's actually some really interesting work that's being done in the heterogeneity of acetylcholine receptor antibodies in myasthenia gravis. So you sometimes think about, if someone has a pathogenic antibody, right? There's this one specific antibody that's causing a problem. And actually, in acetylcholine receptor antibody positive myasthenia, people, particularly who have significant clinical symptoms, seem to actually have a variety of different clones of antibodies. So people will have, the acetylcholine receptor has multiple different subunits, alpha, beta, gamma, fetal subunits. And people with clinical myasthenia gravis seem to have antibodies against more than one of the subunits of the acetylcholine receptor. And it seems that sort of the more different types of antibodies exist, the more clinical symptoms people develop. It's also important to note that about 15% of patients with acetylcholine receptor positive myasthenia also have a thymoma. The next subtype of myasthenia gravis is anti-muscle specific kinase antibody positive myasthenia or anti-MuSK myasthenia. This is much, much rarer. So only about 10% of patients with generalized myasthenia have MuSK antibodies. MuSK doesn't usually cause pure ocular symptoms. So if someone has MuSK antibodies and clinical myasthenia, they're going to have generalized symptoms. MuSK patients often have much more severe disease than those with acetylcholine receptor antibodies. And as a result, we often treat them differently since they tend to be more refractory and they respond a little bit differently to some of the therapeutics that we have. The anti-MuSK antibodies attack MuSK here, which impairs its interaction with another protein called LRP4, and then reduces the activation of this DOX7 pathway, which is responsible for clustering of acetylcholine receptors. So acetylcholine receptors are, if they're sort of randomly scattered across the membrane, the postsynaptic membrane, they're actually less functional. So you need sort of a organized clustering of acetylcholine receptors for the neuromuscular junction to work optimally, and antibodies against MuSK basically disrupt the clustering of acetylcholine receptors on the postsynaptic pathway. An interesting subpoint here, which will become pertinent a little bit later, is that MuSK antibodies are IgG4 antibodies, which does not fix complement. So when I talked about, in the acetylcholine receptor positive disease, those acetylcholine receptor antibodies are typically IgG1, IgG3 antibodies, which avidly fix complement and cause a lot of inflammation at the neuromuscular junction. MuSK antibodies are IgG4 and do not fix complement. The third antibody, the third serotype, is anti-LRP4 positive myasthenia gravis. This is super, super rare. I think I've seen 1 or 2 patients with LRP4 myasthenia. So it's only present in about 1% of generalized myasthenics, or about 10% of patients who have myasthenia, but generalized myasthenia, but no acetylcholine receptor or MuSK antibodies. We tend to treat it a lot like acetylcholine receptor myasthenia. And in terms of pathophysiology, it also disrupts acetylcholine receptor clustering through this DOX7 pathway. Then we're left with seronegative myasthenia, patients who have clinical features of myasthenia and other diagnostic tests that suggest myasthenia, but don't have any of these 3 antibodies. This is about 5% of people with generalized myasthenia, but is much more common in pure ocular myasthenia, maybe up to half of patients, depending on the series that you look at. Seronegative myasthenia is oftentimes treated much like acetylcholine receptor myasthenia, and that's because a lot of these patients actually probably do have acetylcholine receptor antibodies. There's a lot of really interesting work being done in various diagnostic tests that use cell-based assays to detect acetylcholine receptor antibodies, and some newly published articles and posters at various conferences describe roughly 20% of seronegative patients, when tested with a cell-based assay, will actually identify acetylcholine receptor antibodies in these patients. This was really only being done on a research basis until recently, but actually, if any of you have seronegative myasthenics that you'd like to try and test with a cell-based assay, please feel free to reach out to me. There's a lab in Vancouver that's just licensed their cell-based assay to be done through a lab out of Bellingham, Washington, actually. So we now may have a way of sending cell-based assays clinically in patients, which is super exciting and very important. As I'll talk about later in the talk, having acetylcholine receptor antibodies can really expand the range of therapeutic options that are available to patients. So to move on and discuss some of the therapeutic options that are currently available to treat myasthenia. This is a nice overview slide showing the sort of immunologic cascade that leads to myasthenia gravis, and a lot of different agents that act at various points in this cascade. We're not going to go over every single one of these drugs, don't worry, but talk about them sort of as categories. So you can see over here in myasthenia in general, autoreactive T cells interact with B cells, which are then activated, mature into plasma cells, which produce antibodies. Antibodies then bind to the neuromuscular junction, and in some cases, in acetylcholine receptor antibodies, then fix complement, leading to clinical myasthenia. So before we talk about the specific treatments available, let's talk briefly about treatment goals. So our aim when we treat people with myasthenia is to produce either remission, which is no clinical symptoms whatsoever and no physical findings of myasthenia, or minimal manifestation status, which is no clinical symptoms, but maybe some subtle findings on exam. We'll sometimes also use a treatment target called minimal symptom expression, which is having 1 or 2 very mild myasthenia symptoms and some findings on exam. But overall, our goal is for patients to be essentially symptom-free from myasthenia. The important caveat is that we want to do this with minimal side effects from medication. And this is pertinent as we talk about some of the treatments that we use. I could make most myasthenia patients completely symptom-free from myasthenia with like 80 to 100 milligrams of prednisone a day. But doing that long-term is going to produce really intolerable side effects. So in terms of the therapies for myasthenia, I will sometimes group these into the traditional therapies, which are things that we've been using for quite a long time, the targeted therapies, which are some of the newer, sort of more engineered agents that target really specific parts of the immune system. And then I'd also like to talk about some interesting and exciting work that's being done in cell-based therapies, which we may be seeing more in myasthenia in the coming years. To discuss these targeted therapies, these therapies usually work either very proximally in this immune cascade or very distally. So a lot of the traditional immune suppressants really act on sort of these autoreactive T cells and lymphocyte formation. Some of the traditional rescue therapies, which we'll talk more about, plasma exchange and IVIG, actually act at the antibody level, sort of either removing or modifying the way that the body catabolizes antibodies. And then Mestinon, which we'll talk about, acts right on the neuromuscular junction. So to start with Mestinon, which is oftentimes kind of the first thing that we would start to manage symptoms in someone who has myasthenia. Mestinon or pyridostigmine is an acetylcholinesterase inhibitor. So basically, when acetylcholine is released into the neuromuscular junction, it doesn't stay there indefinitely. Acetylcholinesterase is an enzyme that sort of breaks down the acetylcholine that's released into the synaptic cleft. If you inhibit that acetylcholinesterase, it allows sort of a buildup of acetylcholine in the synaptic cleft. You have sort of a higher concentration of acetylcholine that can overcome the impaired safety factor that's the result of these of the pathogenic antibodies. So that inflammatory process that's going on the postsynaptic membrane here is still happening when patients are getting Mestinon. The next traditional therapy that we'll often reach for are corticosteroids or glucocorticoids, mainly prednisone in this country. Glucocorticoids, as most of you probably know, work by reducing inflammation. They sort of promote synthesis of anti-inflammatory proteins and inhibit transcription of inflammatory genes. It works, prednisone corticosteroids work fairly quickly in myasthenia. They act within 2 to 3 weeks. But high doses actually cause transient worsening in up to half of patients with myasthenia. So if you have someone with myasthenia and you put them on 50 milligrams of prednisone a day, about half of them are going to have a significant deterioration in function shortly after starting prednisone, before the sort of therapeutic effect kicks in. As a result, you can't just, give someone with myasthenia, a gram of solumedrol because they've gotten worse, because you may precipitate myasthenic crisis. Rather, you have to start them at sort of a low to moderate dose, usually around 20 milligrams a day, and then gradually up titrate it to a higher level to avoid that transient worsening. It also goes without saying that steroids have a panoply of side effects, and I'm not going to go through all of these, but as I said before, I could make most myasthenic symptoms free just using prednisone, but they would be, all be obese, diabetic, osteoporotic, and, develop cataracts, and, hypertension, have any large number of side effects at the kind of doses you would need to control myasthenia with steroids alone. So, that leads us to some of the oral steroid-sparing agents that fall in this more traditional category. And I'm not going to go through every single one of these, but in general, the ones that you see frequently are azathioprine and mycophenolate are sort of the most commonly used in myasthenia, sometimes methotrexate, tacrolimus, cyclosporin as well. And these drugs generally work by suppressing the immune system, sort of on that more proximal end of the immune cascade. Mycophenolate suppresses sort of cell-mediated immune response and antibody formation. Both azathioprine and methotrexate disrupt nucleotide synthesis. And these medications are great. Many of them work very well in myasthenia, but they take months to have therapeutic effect. Actually, a lot of the clinical trials that were done in azathioprine and Cellcept had negative results. They actually looked like they didn't necessarily have a steroid-sparing effect. And one of the issues that we've had with these trials is that the follow-up time is 3 months, 6 months, which just isn't long enough to see a full therapeutic effect. So Cellcept, you really can't expect to see any benefit from before about 3 months. And I would give folks a trial of at least 6 months before deciding whether a given dose was effective or not. Azathioprine takes more like 9 to 12 months to have therapeutic effect, and it may even take 18 to 24 months to get a full therapeutic effect from any given dose of azathioprine. So these medications, I certainly have patients with myasthenia who ultimately are able to have well-controlled disease on just one of these therapies, but it takes a long time to get there. They also cause a variety of side effects, including infections and leukopenia, GI side effects, impacts on the liver, and these have variable safety in pregnancy. Mycophenolate and methotrexate in particular are absolutely contraindicated in pregnancy, which is a consideration since many myasthenic patients are women of childbearing age and potential. So next to talk about our sort of more traditional rescue therapies, IVIG is one. IVIG is sort of pooled antibodies, pooled immunoglobulins from donors that are sort of isolated and then given as a therapeutic agent. We typically use IVIG. Subcutaneous IG is also available now. And IVIG exerts its effect likely by inducing increased breakdown and reducing recycling of endogenous IgG. I'll talk a little bit more about this pathway when I talk about FCRN inhibitors a little bit later in the talk. There's also plasmapheresis, which works by directly removing pathogenic antibodies. And these therapies are used to treat severe myasthenia exacerbation or myasthenic crisis, which is respiratory impairment as a result of myasthenia gravis. And they're used sort of as rescue medications because they work pretty quickly. They kick in within about 1 to 2 weeks. You'll see maximal effect. So if someone is doing really poorly, having a flare of myasthenia because of a surgery, an infection, pregnancy, a medication that they got that worsened their myasthenia, IVIG or plasmapheresis are effective therapies. Sometimes they're also used for chronic treatment. In patients who have either very severe or very refractory myasthenia, they'll get IVIG every couple of weeks or every month. They might get plasmapheresis every few weeks to help control their symptoms. And then this isn't a drug, but really more a therapeutic maneuver that we will use for myasthenia gravis. So we'll use thymectomy in myasthenia. Patients, those 15% of acetylcholine receptor antibody positive patients who have a thymoma should absolutely get thymectomy. So that is a circumstance in which thymectomy is indicated 100% of the time if someone actually has a thymoma. However, in patients who don't have thymoma, it's long been supposed that taking out the thymus could improve the myasthenia, that the thymus is somehow involved in the pathophysiology, the pathogenesis of myasthenia. And in sort of the 2010s, they actually did a randomized, single-blinded, controlled study of thymectomy in generalized acetylcholine receptor positive myasthenia patients. And it showed that folks who, in that group of patients who underwent thymectomy, overall had less severe disease and were on lower doses of steroids at the end of the trial period, which was over several years. Now, it does take probably about 3 years to see a difference between patients who got thymectomy and didn't. So this isn't something, it's not like you take out the thymus and someone gets better right away. It's more like an investment for the future. If you take out the thymus, over the coming years, the disease may be somewhat less severe. So in patients who have acetylcholine receptor antibodies and generalized disease, thymectomy could be considered if they're in sort of the 18 to 50 year range. Over 50, I usually, I may or may not offer thymectomy. It depends a little bit on their overall health status. It does seem that patients who are younger and who were earlier in their disease course had a greater benefit from thymectomy than patients who were older and who had myasthenia for many years. Thymectomy should be performed when the patient is stable. So if someone has really poorly controlled myasthenia, is kind of teetering on the brink of crisis, that's not when you want to have a thymectomy done, because going through that surgery could provoke frank myasthenic crisis. So, folks don't have to be in remission or minimal manifestations, but you want to wait to do this surgery until someone is really stable. Similarly, if someone is diagnosed with myasthenia while they're pregnant, you don't want to do the thymectomy during pregnancy. You would wait until after delivery. In seronegative patients, we don't have the same trial data that we do for the acetylcholine receptor antibody positive patients. So we might consider thymectomy in seronegative patients who are refractory. And in patients who have pure ocular myasthenia, if they're refractory and they have acetylcholine receptor antibodies, we might consider a thymectomy. For patients with MuSK or LRP antibodies, there's no clear benefit for thymectomy. So to move on and discuss some of the mechanisms of action of the more targeted and emerging immunotherapies, which is the part of this that I find the most interesting. So we'll talk a little bit about anti-CD20 agents, complement inhibitors, and FCRN inhibitors, all of which are available on the market to treat myasthenia currently. So these drugs, variety of these drugs, work sort of in the middle of this immune cascade. Starting with the anti-CD20 agents, with rituximab being the one that's most readily available. This works basically by going after the anti-CD20 agents or monoclonal antibodies that bind to cell surface receptors on activated B cells and then results in sort of an immune attack that targets the B cells themselves, basically reducing the antibody-producing cells that make MuSK antibodies, acetylcholine receptor antibodies, LRP4 antibodies, and then overall reducing those pathogenic antibodies that attack the neuromuscular junction. We actually don't have a lot of good prospective data for rituximab. In acetylcholine receptor antibody positive disease, the BEAT-MG study actually didn't show benefit for rituximab over 12 months in patients with generalized acetylcholine receptor antibody positive disease. In MuSK myasthenia, it's really hard to run prospective trials because MuSK positive disease is so very rare. And the best that we have is a blinded prospective review that suggests the benefit of rituximab in MuSK patients. So the international consensus guidelines, the updated guidelines that were released, I think back in 2020 or so, recommend that rituximab be considered actually early in MuSK positive disease. While we don't have great prospective data, expert opinion is that rituximab works very well in many patients with MuSK myasthenia. That's certainly been my clinical experience. So usually if someone isn't doing well on mestinon and prednisone, I'll jump right to rituximab in folks with MuSK positive disease rather than playing around with some of the other immune suppressants. In contrast, in acetylcholine receptor positive disease, I probably wouldn't reach for rituximab unless someone is very refractory. And actually, now that we have some of the other therapies that I'll talk about next, rituximab is going to fall pretty far down on the list of medications that I would try in someone with acetylcholine receptor positive myasthenia. There's some work suggesting that rituximab might be more effective early in the disease course, that part of why it may not be effective in acetylcholine receptor antibody positive myasthenia is that there's something about the B cells and the plasma cells that develop and participate in the immune response in myasthenia, that once that's been sort of set up and established, the CD positive 20B cells maybe aren't participating quite as much. So that'll be an interesting line of inquiry to watch in the future, that maybe rituximab is a great drug to use in the first year after diagnosis, but after that, maybe less effective. Just a side note is this also takes a little while to work. Time to therapeutic effect is typically about 3 to 6 months in myasthenia. So then the next type of targeted therapy I want to talk about is complement inhibition. So as we discussed, specifically in acetylcholine receptor antibody positive myasthenia, complement activation is an important part of the immune attack in myasthenia gravis. The pathogenic acetylcholine receptor antibodies fix their target at the neuromuscular junction and then activate complement. If you're anything like me, you learned about complement in medical school, memorized it for the immunology test, and then promptly prayed you would never have to remember it again. Revisited it for step 1, maybe step 2, and then kind of like tore out the page and threw it away because it's, you know, torturous to remember. Unfortunately, complement has come back to haunt neuromuscular physicians and also a variety of other neurologists in the years since then. But essentially, without going into all of the nitty-gritty details, what happens is in this complement cascade is that an antigen-antibody complex, so antibodies that have bound to their antigen, then bind complement, C1. It activates this whole cascade, which terminates in the cleavage of C5 into C5a and C5b. C5a recruits pro-inflammatory cytokines to the location of complement binding, and C5b triggers clustering of C6, C7, C8, C9, and forms a membrane attack complex, which actually then targets the cell membrane at the site of complement binding as well. So it's been long, for quite a few years, hypothesized that if you could block complement activation, you could block a lot of the pathogenic effect of antibody binding at the neuromuscular junction. By sort of blocking the cleavage of C5 into C5a and C5b. And there are 2 drugs on the market right now that do this in myasthenia. So eculizumab or Soliris and ravulizumab or Ultomiris are monoclonal antibodies that block the cleavage of C5 into C5a and C5b. And these have been shown in phase 3 clinical trials to be effective in treating acetylcholine receptor antibody positive generalized myasthenia. So Regain for eculizumab and Champion for ravulizumab. Eculizumab was sort of the first generation of these therapies that came on the market around 2017, and it's an IV drug that's dosed every 2 weeks. Ravulizumab is kind of the second generation. They did some fun engineering with it to increase its affinity for FCRN, basically prolonging its half-life. So it's very similar to eculizumab, but is infused every 2 months instead of every 2 weeks. There are also some subcutaneous complement inhibitors that are being investigated. And overall, this is something that is a good option for patients who have generalized acetylcholine receptor antibody positive disease. Interestingly, it would not be effective in MuSK myasthenia because, as I mentioned, MuSK antibodies are IgG4 antibodies that do not bind complement. So complement inhibitors wouldn't have an impact in MuSK positive disease. Another important note is that patients getting complement inhibition have to be vaccinated against meningitis A and meningitis B. In some of the early clinical trials, one of the sort of big safety signals that came up was meningococcal infection. And it makes sense why that would be. Encapsulated bacteria like meningococcus, the immune response against them relies heavily on this membrane attack complex. So if you block this membrane attack complex formation, your body is really not going to be able to fight those encapsulated bacteria in the same way. So patients who are starting these therapies need to be vaccinated against meningococcus. And if the therapy needs to be started, within 2 weeks of vaccination, you actually need to prophylax them with antibiotics to prevent meningococcal infection. In the era now where anyone on complement inhibition is vaccinated and we, talk to the patients about early warning signs of meningococcal infection, the risk of infection or adverse impacts from that are actually quite low. The next targeted therapy that I'd like to discuss are FCRN inhibitors. So just to introduce everyone to this pathway, in case you're not familiar with it, FCRN receptors basically facilitate IgG recycling and prolong the half-life of immunoglobulins. In this cartoon here, you can see a bunch of different antibodies, some of which are sort of normal IgG antibodies and others of which are pathogenic antibodies. FCRN receptors exist on many different cells in the body. They're called, they were originally identified in participating in transplacental passage of maternal antibodies into the fetus. But they also exist, prominently on endothelial cells. So endothelial cells are sort of constantly sampling plasma, taking in plasma, including antibodies. Antibodies can bind to FCRN receptors. And basically, antibodies that are bound to FCRN receptors are protected, while unbound antibody is shunted towards lysosomal degradation. So unbound antibodies get broken down, bound antibodies get protected and then released back into circulation. So FCRN receptors promote protection of antibodies, recycling of antibodies, and overall prolong their half-life. Interestingly, it's this pathway that probably explains the mechanism of action of IVIG or subcutaneous IG. So you can imagine if you were to give someone a whole bunch of exogenous immunoglobulin, then you'd have a whole lot of exogenous non-pathogenic immunoglobulin, and a relatively smaller proportion of the IG hanging out is your sort of endogenous IG, which includes the pathogenic antibodies. If there's a lot of IVIG that's out there, you're going to end up with a lot of these FCRN binding sites being taken up by that IVIG, by the exogenous IG. And then you have relatively more unbound antibody that includes the pathogenic antibodies that are then shunted towards lysosomal degradation. So FCRN inhibitors are compounds or drugs that bind with high affinity to the FCRN receptors, leaving relatively more unbound antibody that's then shunted towards lysosomal degradation. So basically, you shorten the half-life and reduce the amount of pathogenic antibody that exists in circulation. Efgartigimod is the drug that's on the market currently, which is an FCRN inhibitor, and it was shown in a phase 3 trial called ADAPT to be effective in treating acetylcholine receptor positive myasthenia. So its clinical or its labeling indication is for generalized acetylcholine receptor antibody myasthenia. So theoretically, FCRN inhibitors should be effective in MuSK, LRP4, and seronegative myasthenia, presuming that there's some sort of pathogenic antibody that we're not identifying in the seronegative patients. FCRN receptors bind to any IG subtype, so IgG 1, 2, 3, 4, all bind to FCRN. Unfortunately, in the ADAPT trial, the numbers of LRP4, MuSK, and seronegative patients were very small. So there just weren't enough patients to see whether there was a therapeutic effect or not. But again, theoretically, FCRN inhibition should work in those rarer subtypes of myasthenia as well. And there are quite a few other FCRN inhibitors in clinical trials. Efgartigimod is an IV infusion that's given once every 4 weeks or once every week for 4 weeks. So a round of therapy is sort of 4 weekly infusions, and then it's redosed at a flexible interval, kind of depending on how the patient responds to it. Some of the other FCRN inhibitors that are in trials are either subcutaneous infusions or subcutaneous injections, which might provide a little bit more flexibility in dosing for patients. So to shift now and talk about some therapeutics that are sort of being in early investigation stage and on the horizon, cell-based therapies, including CAR-T therapies and CAART therapies, I think are sort of an interesting and promising line of inquiry. CAR-T therapies act at the cellular level. And to review what CAR-T is, a lot of you may have heard of it in the setting of oncology and treatment for B-cell leukemias and lymphomas. So basically, a chimeric antigen receptor, or CAR, is an artificially designed T-cell receptor that recognizes specific cell proteins and then helps kill those particular cell types of interest. The CAR, or CAR, has this single chain variable fragment, which is basically is very similar to the FAB, or antigen binding site on an antibody. This single chain variable fragment recognizes one specific protein, and when bound, signals the T cell to coordinate an immune attack against the target cell, which has the recognized protein. In CAR therapy, either a DNA or engineered RNA vector is introduced into the patient's own T cells. So T cells are typically harvested, and then a DNA or mRNA vector is introduced into those T cells, which then produces this specifically designed CAR receptor, those CAR T cells, those CAR T cells, are then infused back into the patient. And these CAR T cells then coordinate an immune attack against the cell of interest. So this has been used to treat B-cell leukemias and lymphomas with the first sort of version of this therapy, consisting of CARs that target CD19. It is also being investigated in a variety of other cancers. Really, the limitation to this is the severe toxicity that it produces. So it results in oftentimes a cytokine release syndrome, neurotoxicity, and these DNA vector CAR T cells, at least, oftentimes will sort of exponentially increase. They have a really unpredictable response. So sometimes people might respond very mildly to them. Sometimes you might have a rapid expansion of the CAR T cells and get a really severe cytokine release syndrome. So I was a medical intern at Penn in the early 2010s when some of these clinical trials were being done, and we always dreaded rotating on the oncology services. We called this the catastrophe syndrome because of how severe and life-threatening it could be. So it's really this DNA engineered CAR T therapy is fantastic and very promising, but really not appropriate for use outside of sort of life-threatening, very severe diseases like refractory B-cell leukemias and lymphomas. In contrast, mRNA engineered CAR T cells have a more predictable and milder impact on their host. So rather than introducing a DNA vector, mRNA engineered CAR T cells introduce engineered mRNA into the patient's T cells, which produce a chimeric antigen receptor, but rather than sort of persisting and exponentially increasing, over time the engineered mRNA is degraded and sort of declines in these T cells. So you can actually sort of periodically dose someone with mRNA engineered CAR T cells, and you get a much more predictable sort of drug-like pharmacokinetic reaction. You can really control the exposure and improve safety. And this is actually being trialed in a variety of diseases that are actually being infused as an outpatient. So you don't have to be sort of admitted and closely monitored the way someone might be in DNA-based engineered cells. So taking this one step further, CAR-T or chimeric autoantigen receptor T cells are engineered to target specific B-cell receptors. So rather than developing a chimeric antigen receptor that targets like CD19, which exists on, all activated B cells, what if you could design a chimeric antigen receptor that only targets certain activated B-cell receptors? So rather than targeting all B cells, you're only targeting B cells that have receptors that are expressing like an anti-MuSK B-cell receptor. This is being trialed and basically allows us to introduce a very targeted agent that seeks and destroys just specific populations of activated B cells. So rather than killing off all of your B cells, you're only targeting the B cells that are producing a specific pathogenic antibody. So I think this is being looked at in animal models currently, and sort of a very exciting, therapeutic prospect, not just in myasthenia, but also in a lot of other autoimmune diseases. Now, you'll notice here that I mentioned that this is being looked at specifically in myasthenia. Why not acetylcholine receptor antibody positive myasthenia? Well, it is something that could be considered in acetylcholine receptor antibody myasthenia in the future, certainly. But if you'll recall, one of the things about acetylcholine receptor positive myasthenia I mentioned is that there's not just a single acetylcholine receptor antibody in patients with myasthenia. Patients with acetylcholine receptor antibody myasthenia usually have several different populations, different clones of acetylcholine receptor antibodies that are needed to produce the immunologic sort of activation at the neuromuscular junction. So if you wanted to treat acetylcholine receptor antibody myasthenia, you would need a bunch of different specific chimeric antigen receptors, each of which targets a different B cell population, which is producing different sort of clones of the acetylcholine receptor antibody, which, maybe that could happen in the future, but MuSK is a better target for something like this because there's just typically a single clonal population of B cells producing a single antibody type that produces the disease. So I would be remiss if I didn't touch on sort of cost and administration comparison in these therapies. Clearly a lot of these newly available therapies and what's on the horizon are really exciting, sort of being able to target very specific parts of the immune system in order to sort of minimize the overall potential side effects on patients, and also, target the specific pathologic pathway in a disease without having quite as many off-target effects on other parts of the immune system that we still want to be intact and functioning for patients to be as healthy as they possibly can be. But a lot of these novel therapies come with a pretty hefty price tag. So, comparing to the older therapies, prednisone, right, is pretty dirt cheap, usually about $15 a month or less, right? Azathioprine and mycophenolate are usually dosed twice a day, and they're a couple $100s a month. So more expensive than prednisone, but still certainly quite affordable. IVIG, which we think of as being a very expensive therapy, is expensive. A course of IVIG would typically cost $20,000 to $35,000 for a course. And, sometimes it's used just as rescue therapy. Patients on maintenance IVIG usually get it about monthly or maybe every few weeks. Plasmapheresis, also about $20,000 to $35,000 a course for a course of 5 exchanges. And how that's dosed, how the pheresis is scheduled really varies by patient. Rituximab, the anti-B cell rituximab, is dosed every 6 to 12 months, and it costs about $20,000 for a course. So annual cost would be $20,000 to $40,000. Eculizumab, the complement inhibitor, as I had mentioned, it's dosed every 2 weeks in its maintenance phase, and it costs about $60,000 per month. So something like $700,000 a year, which is obviously very expensive. Now, what that price ends up being, it varies by sort of the institutional buyer. Obviously, patients aren't paying $700,000 a year for this, but it's a very, very expensive therapy. The newer ravulizumab, it's a little bit less expensive. It's about $60,000 for a course, and it's given every 2 months. But this is still obviously going to be extremely expensive. And then efgartigimod is dosed, as I'd mentioned before. It's a once-a-week infusion over 4 weeks. That's one round of therapy. And then additional rounds of therapy can be given depending on a patient's response. A 4-week cycle costs about $40,000, and then obviously plus the infusion costs. What some of these cell-based therapies could cost, the CAR T therapies or CAART therapies, we don't know, but they would likely be very expensive since they're sort of very personalized therapies. So, how this plays a role in clinical practice currently, when I'm treating someone with myasthenia, my goal is for the patient that I'm working with to have disease that's controlled with the least side effects that they can. So, I don't necessarily see my role when I interact with each individual patient. I don't see my role as being to sort of ration healthcare. And oftentimes, insurance companies at this point, insurance companies do a lot of the gatekeeping around costs, where they may not approve one of these more advanced therapies until someone has not responded to some other therapies. Although, ravulizumab, efgartigimod, in those clinical trials, patients didn't need to have failed a lot of other therapies in order to qualify for those trials. And the labeling indication is just for, generalized acetylcholine receptor positive myasthenia gravis. So could these be used right after Mestinon? Certainly. Is insurance going to let you do that? Maybe, maybe not. But even if I, as a physician, am not sort of, I'm saying my role isn't to necessarily take into account the overall impact on the healthcare system. When I'm seeing a patient, my responsibility is to them and giving them the best care that I can. it is important, I think, as a profession overall, to think about the impact that drugs that are this expensive have on our healthcare system, and participate in sort of decision making and stewards at a broader level, so that the decisions around how these drugs are used and paid for isn't just left to insurance companies. So that's it for my talk today. Thank you so much for your time and attention. I'd be happy to answer any questions, and if anyone is interested, I have a variety of references here as well.
Thank you so much, Christyn. That was fabulous. Any questions? Go ahead and write them in the chat, or I'll just kind of throw one out, Christyn. So, like, it seems like some of these new therapies are really changing the way we potentially treat a newly diagnosed myasthenia patient, whereas when we're transitioning them from an initial treatment with mestinon and prednisone to some other long-term disease-modifying therapy. What are your thoughts around that, of these new therapies, which ones you tend to gravitate towards?
Yeah, so that's a great question, and it depends a little bit on the patient. If someone, you're certainly right that if someone comes to see me and has relatively newly diagnosed myasthenia, if it's sort of even moderately severe and they don't have adequate control with prednisone and mestinon, rather than reaching for Cellcept or Imuran, which are going to take many months to have an effect, I might be reaching for one of these newer therapies because they do act more quickly. And I didn't give you those pharmacokinetic curves, but complement inhibitors can have a therapeutic effect within 2 or 3 weeks, and FCRN inhibition as well. You are seeing a therapeutic effect within a week or 2, oftentimes, of starting these medications. So whether I'm opting for something like, I would say that looking at the complement inhibitors, I would prefer ravulizumab over eculizumab now. Just a every 2-month infusion versus an every 2-week infusion is going to be so much easier for patients. And looking at that versus efgartigimod, there aren't any head-to-head trials, but it might depend a little bit on how a patient feels about having their treatment tailored to them, right? Ravulizumab and eculizumab have a set dosing regimen, like you get it every 2 weeks or every 2 months. There's no adjustment in dose, there's no adjustment in interval, at least at this point you have this sort of set dosing. Whereas efgartigimod is going to be 4 weekly infusions, and then you kind of see how the patient does. You wouldn't infuse again for about 2 months after starting that first round of infusions. In the clinical trials, there were a pretty significant proportion of patients who went more than 12 weeks, had a significant response, and then went more than 12 weeks without needing a second round of infusions. So, one of the things that efgartigimod offers with its current labeling is that you have some flexibility in dosing, where you can give it to a patient, see how they respond, and if they do really well, you don't necessarily need to dose them again until they have a clinical decline. Some of it might depend a little bit on their planned pregnancy, if they're interested in pregnancy. None of these drugs have been studied specifically in pregnancy, but the complement inhibitors are also used in atypical HUS and PNH, which can present in pregnant women and can be very severe and threatening to the life of the mother and the fetus. So they actually have pretty big databases showing outcomes of pregnancies that have been exposed to complement inhibition in the PNH HUS space. And large databases, usually a couple hundred patients is what we see. But the safety data from those registries looks pretty decent. So, if I had to pick between, an FCRN inhibitor versus a complement inhibitor, there's more data. In someone who's pregnant, there's more data in the complement inhibition space. But what I would say is with any myasthenia patient, there's not necessarily a strict algorithm that I use, and it really, really depends on the patient, on the severity of their symptoms, and on, their lifestyle and preferences around treatment. someone who's eligible for a C5 inhibitor or an FCRN inhibitor who has pretty severe disease, who I think, would benefit, and I'm offering it to them, they may say, I really don't want to be tied to infusions. I'm willing to wait longer. Try one of the more traditional oral therapies, give that time to work. And then if that works, I'm taking a pill twice a day and not tied to infusions. Another way that some of these novel therapies might be used that, isn't sort of how they're labeled, but I can imagine that in the future they might be used sort of as rescue or intermediate acting therapies. If complement inhibitors act within a week or a few weeks, if someone presents to the hospital with really severe myasthenia, is newly diagnosed, maybe you treat them with IVIG, give them a dose of a complement inhibitor, and then simultaneously start them on azathioprine, and then, maybe use that complement inhibitor until the azathioprine has time to take effect. Or potentially even using the efgartigimod in a similar way. That's really dropping that pathogenic antibody in the same way that IVIG, or to a lesser degree plasmapheresis, would. Maybe these have a role in being used as rescue therapies and or sort of a bridge, where you're using these newer therapies as a bridge until you get that therapeutic effect of some of the sort of cheaper, easier to take, older steroid-sparing agents.
That's great. Yeah, thank you.
None of that is FDA approved. that's all just me speculating.
Looks like there's lots of comments, but also potentially some questions in the chat. And let's see here. Great talk, thank you. Question about MG crisis in the ICU. This is from Ali. When patients are intubated, I generally hold Mestinon due to the risk of increased oral secretions, which could inhibit extubation. Is this an old theory? And would you recommend starting cholinesterase inhibitors in the ICU for refractory ventilated patients?
So that's a great question. And it is an old theory, but I think it still holds true. That in general, if someone is intubated or nearing intubation, that we hold the acetylcholinesterase inhibitors. The reality is that Mestinon, it works, but not great, especially for respiratory symptoms. So if someone has myasthenic crisis that's so severe that they're considering intubation, Mestinon isn't going to be the thing that prevents them from being intubated. In terms of someone who's sort of like chronically intubated and can't get off the vent, sort of similar, it's unlikely that Mestinon is going to provide enough benefit that it's going to be the thing that gets them extubated. And because it does increase respiratory secretions, we worry about patients developing pneumonias or otherwise sort of having difficulty managing those increased secretions. So I would certainly still advise that patients who are either intubated or sort of having a myasthenic crisis with a significant respiratory component, I would still recommend holding those cholinesterase inhibitors.
And then David wrote, David Vanek, great talk, Christyn. What I've been uncertain of since it's so new is whether when I'm starting someone on efgartigimod, whether to start something like Cellcept as well for long-term control. I have generally been starting Cellcept with the idea that maybe we won't need infusions long-term, but curious about your approach.
Yeah, I think that's absolutely a reasonable approach to consider, just if we're starting some of these therapies, the C5 inhibitors or the FCRN inhibitors, that maybe we look at them as bridge therapies, right? That, someone might be on this for a year or two while you're using some of these more traditional immune suppressants. That's certainly a reasonable strategy. There's some patients who can't do that for whatever reason. Maybe they've had a severe flu-like reaction with azathioprine, or perhaps they've had, certain types of infections that would make one leery about using Cellcept, methotrexate, azathioprine. But it would certainly be reasonable to think of some of these newer therapies more as bridge therapies. I was going to say about that. Is that sort of when you think about the mechanism of action, especially of the complement inhibitors, if you think about it, that blockade of the complement, of terminal complement, really only addresses one of the mechanisms of sort of pathogenicity of acetylcholine receptor antibodies, the complement activation. Even if you have someone who's, their complement activity is fully blocked, with those acetylcholine receptor antibodies, you're still going to have antibody cross-linking and internalization. You're still going to have some blockade of the acetylcholine receptor. So at least early on, when these complement inhibitors came out, especially since eculizumab was really studied in pretty refractory patients, everyone in the REGAIN trial was on other immune suppressants. There was this question of, could someone only be on a complement inhibitor? So if they're on a complement inhibitor, you're blocking that complement activation, but you're not doing anything about antibody production. You're not doing anything about antibody blockade of acetylcholine receptors. You're not doing anything about sort of the cross-linking and internalization of receptors. We do, eculizumab has been around long enough now that we actually do see that there are some patients who can just be on complement inhibition, and they don't have significant myasthenia symptoms. So complement inhibitors, it seems, can be used in some cases as monotherapy. But for other patients, they may actually need both complement inhibition and also immunosuppression at a more proximal level to actually, take down some of these autoreactive B cells, reduce the production of antibody, and also block complement inhibition at the neuromuscular junction.
Yeah, great answer. We have some other questions, but I also want to be respectful of people's time. It's after 8:30. Maybe what we could do is kind of take those offline. And I know Christyn's super open to answering questions. Could be followed up by email or telephone. So again, thank you so much, Christyn,